Bismillah ar-Rahman ar-Rahim. Our lecture today is nephrotic syndrome. Nephrotic syndrome, a manifestation of a glomerular disease, is characterized by nephrotic range proteinuria and the triad of clinical findings associated with large urinary loss of protein, that is, hypoalbuminemia, edema, and hyperlipidemia. It is primarily a pediatric disease, and it is 15 times more common in children than adults. Nephrotic range proteinuria is defined as protein excretion of more than 40 mg per meter square per hour, or a first morning protein to creatine ratio of more than 2 to 3 to 1. The annual incidence is 2 to 3 cases per 100,000 children per year in most Western countries, and higher in underdeveloped countries, resulting predominantly from malaria. Etiology of nephrotic syndrome. Most children with nephrotic syndrome have a form of primary or idiopathic nephrotic syndrome. Nephrotic syndrome may also be secondary to systemic diseases. A number of hereditary proteinuria syndromes are caused by mutations in genes that encode critical protein components of the glomerular filtration apparatus. Pathophysiology of nephrotic syndrome. The underlying abnormality is an increased permeability of the glomerular capillary wall, which leads to massive proteinuria and hypoalbuminemia. On biopsy, the extensive effacement of podocytes, food process, the hallmark of idiopathic nephrotic syndrome, suggests a pivotal roles for the podocytes. Idiopathic nephrotic syndrome is associated with complex disturbances in the immune system, especially T-cell mediated immunity. In focal segmental glomerulosclerosis, a plasma factor probably produced by a subset of activated lymphocytes may be responsible for the increase in capillary wall permeability. Mutations in podocytes proteins or genes are associated with focal segmental glomerulosclerosis. Steroid-resistant nephrotic syndrome can be associated with the mutations in some genes of the glomerular filtration apparatus. Although the mechanism of edema information in nephrotic syndrome is incompletely understood, it seems likely that in most instances massive urinary protein loss leads to hypoalbuminemia, which causes a decrease in plasma oncotic pressure and transudation of fluid from the intravascular compartment to the interstitial space. The reduction in intravascular volume decreases renal perfusion pressure, activating the renin-angiotensin-aldosterone system, which stimulates tubular reabsorption of sodium. The reduced intravascular volume also stimulates the release of antidiuretic hormone, which enhance the reabsorption of water in the collecting duct. The reabsorbed fluid will shift from intravascular space to interstitial space due to decreased plasma oncotic pressure and causes increasing edema. The previous theory does not apply to all patients with nephrotic syndrome because some patients have an increased intravascular volume and decreased plasma level of renin and aldosterone. Therefore, other factors, including primary renal avidity for sodium and water, may contribute to the formation of edema. In nephrotic state, serum lipid levels, cholesterol and triglycerides are elevated due to when hypoalbuminemia stimulates generalized hepatic protein synthesis, including synthesis of lipoprotein. This is also why a number of coagulation factors are increasing the risk of thrombosis. 2. Lipid catabolism is diminished as a result of reduced plasma level of lipoprotein lipase related to increased urinary losses of this enzyme. There is an increased risk of infection like sepsis, peritonitis, pyonephritis, especially with encapsulated organisms such as Streptococcus pneumoniae and Haemophilus influenza. Causes include 1. Urinary losses of immunoglobulins and property factor B. 2. Defective cell-mediated immunity. 3. Immunosuppressive therapy. 4. Malnutrition. 5. Edema or ascites acting as a potential culture medium. Nephrotic syndrome is a hypercoagulable state resulting from multiple factors. 1. Vascular stasis. 2. An increase in hepatic production of fibrinogen and other clotting factors. 3. Decreased serum level of anticoagulant factors. 4. Increased plasma platelet production as an acute phase reactant. And 5. Increased platelet aggregation. The coagulopathy manifests with thromboembolic events. Now we talk about the most common type of nephrotic syndrome, which is idiopathic nephrotic syndrome. Approximately 90% of children with nephrotic syndrome have idiopathic nephrotic syndrome. Idiopathic nephrotic syndrome is associated with primary glomerular disease without evidence of specific systemic cause. Idiopathic nephrotic syndrome includes multiple histological types. 1. Minimal change nephrotic syndrome represent about 85% of cases of nephrotic syndrome. The glomeruli appear normal or show a minimal increase in mesangial cell and matrix. Findings on immunofluorescence microscopy are typically negative, and electron microscopy simply reveals effacement of the epithelial cell photoprocesses. More than 95% of children with minimal change nephrotic syndrome respond to corticosteroid therapy. 2. Mesangial proliferation. Approximately 50% of patients respond to corticosteroid therapy. 3. Focal segmental glomerulosclerosis. Only 20% of patients respond to corticosteroid therapy. It is often progressive, ultimately involving all glomeruli and ultimately lead to end-stage renal disease in most patients. 4. Membranous nephropathy, and 5th, membranoproliferative glomerulonephritis. The clinical presentations of nephrotic syndrome. It is more common, idiopathic nephrotic syndrome is more common in males. Male to female ratio is 2:1, and most common between 2 to 6 years, but it may present as early as 6 months of age until adulthood. Minimal change nephrotic syndrome is present in 85 to 90% of patients less than 6 years of age, and only 20 to 30% of adolescents, in which focal segmental glomerulosclerosis present the more common cause. The incidence of focal segmental glomerulosclerosis may be increasing, and it may be more common in African American, Hispanic, and Asian patients. The initial episode and the subsequent relapses may follow minor infections and occasionally a reaction to insect bites, bee stings, or poison ivy. Patients usually present with mild edema, which is initially noted around the eye and in the lower extremities. Nephrotic syndrome may initially be misdiagnosed as an allergic reaction because of the periorbital swelling that decreases throughout the day. With time, the edema becomes generalized with the development of ascites, pleural effusion, and genital edema. Anorexia, irritability, abdominal pain, and diarrhea are common. Hypertension and hematuria are uncommon. The differential diagnosis of nephrotic syndrome include causes of marked edema like 1. Protein losing enteropathy. 2. Hepatic failure. 3. Congestive heart failure. 4. Acute or chronic glomerulonephritis. 5. Protein malnutrition. A diagnosis other than minimal change nephrotic syndrome should be considered in children less than 1 year of age. A positive family history of nephrotic syndrome. Presence of extrarenal findings like arthritis, rash, anemia, hypertension or pulmonary edema, acute or chronic renal insufficiency, and gross hematuria. Now we speak about the diagnosis of nephrotic syndrome by general urine examination revealing 3 plus to 4 plus proteinuria, urinary protein excretion more than 40 mg per meter square per hour, spot urinary protein to creatinine ratio more than 2, serum creatinine is usually normal, but may be abnormally elevated if there is diminished renal perfusion from contraction of the intravascular volume. Serum albumin less than 2.5 gram per deciliter. Serum cholesterol and serum triglyceride are elevated. Serum complement levels are normal. Microscopic hematuria seen in 20% of cases. Renal biopsy is not routinely performed if the patient fits with the standard clinical picture of minimal change nephrotic syndrome. Children with features that makes minimal change nephrotic syndrome less likely, like gross hematuria, hypertension, renal insufficiency, hypocomplementemia, and if age of onset less than 1 year or more than 8 years, should be considered for renal biopsy before treatment. Treatment of nephrotic syndrome. Steroid therapy. Children with onset of uncomplicated nephrotic syndrome between 1 and 8 years of age are likely to have steroid responsive minimal change nephrotic syndrome, and steroid therapy may be initiated without a diagnostic renal biopsy. Initial attack, we give prednisolone 60 mg per meter square per a day. Maximum dose is 80 mg given in a single daily dose for 4 to 6 consecutive weeks after confirming a negative PPD test and administering the polyvalent pneumococcal vaccine. More than 95% of children will respond to steroid therapy, which is defined as a clinical remission, diuresis, and urine trace are negative for protein for 3 consecutive days. After the initial course, the prednisone dose should be tapered to 40 mg per meter square per day, given every other day as a single daily dose for at least 4 weeks, with slow tapering and discontinuation over the next 1 to 2 months. In case of relapse, many children with nephrotic syndrome experience at least one relapse, that is 3 to 4 plus proteinuria plus edema. Although relapse rate of 60 to 80% have been noted in the past, the relapse rate in children treated with longer initial steroid course may be as low as 30 to 40%. Relapse should be treated with prednisone 60 mg per meter square per day. Maximum dose is 80 mg in a single morning dose until the child enter remission. The prednisone dose is then changed to alternate day dosing as noted with initial therapy and gradually tapered over 1 to 2 months. Diuretics therapy. In mild to moderate edema, we have to give low sodium diet enter remission. Although there are no data to support their safety or efficacy, oral diuretics are used by many clinicians to control edema and in children with nephrotic syndrome. Because of the increased risk of thromboembolic complications, diuretics use should be reserved for patients with severe symptoms and must be closely monitored. In severe symptomatic edema, as large pleural effusion, ascites, or severe genital edema, the child should be hospitalized with sodium restriction, and fluid restriction may be necessary if the child is hyponatremic. A swollen scrotum may be elevated by pillows to enhance fluid removal by gravity. Diuresis may be augmented by the administration of loop diuretics like furosemide, orally or IV, although extreme caution should be exercised. Aggressive diuresis can lead to intravascular volume depletion and a significantly increased risk of intravascular thrombosis. When a patient has significant generalized edema with evidence of intravascular volume depletion, for example in hemoconcentration, IV administration of 25% albumin, 0.5 to 1 gram albumin per kg, as a slow infusion followed by furosemide, 1 to 2 mg per kg per dose. IV is sometimes necessary. Such therapy should be used only in collaboration with the pediatric nephrologists and mandate close monitoring of volume status, blood pressure, serum electrolytes balance, and renal function. Symptomatic volume overload with hypertension, heart failure, and pulmonary edema is a potential complications of parenteral albumin therapy, particularly when administered as a rapid infusion. Children with nephrotic syndrome should attend school and participate in physical activities as tolerated. Now we have to define what we call steroid-resistant nephrotic syndrome. It is those children who continue to have proteinuria that is more or equal to 2 plus proteinuria after 8 weeks of steroid therapy. The child is in need for diagnostic renal biopsy. It is usually caused by focal segmental glomerulosclerosis, about 80%, minimal change nephrotic syndrome, or mesangial proliferative glomerulonephritis. While steroid-dependent nephrotic syndrome is defined as relapse, that is 3 to 4 proteinuria plus edema, while on alternate day therapy or within 28 days of completing a successful course of prednisone therapy. Frequent relapses is defined in patients who respond well to prednisone therapy but relapses more than or equal to 4 times in 12 months period. Steroid-dependent patients, frequent relapsers, and steroid-resistant patients are candidates for alternative therapy, particularly if the child has severe corticosteroid toxicity like coccinioid appearance, hypertension, cataracts, and or growth failure. The alternative therapy may include the following options. First, cyclophosphamide 2 mg per kg per day as a single oral dose for 2 to 3 months with alternate day steroid therapy. Side effects include neutropenia, disseminated varicella, hemorrhagic cystitis, alopecia, sterility, and increased risk of future malignancy. YTC count must be done weekly, and the drug should be withheld if the count is less than 5,000 per cubic millimeter. Second, cyclosporine or tacrolimus. Side effects include hypertension, nephrotoxicity, hirsutism, and gingival hyperplasia. Third, mycophenolate. Fourth, levimazole, which is an antihelminthic agent with immunomodulating effect. Most patients who respond cyclosporine, tacrolimus, or mycophenolate therapy tend to relapse when the medication is discontinued. Angiotensin-converting enzyme inhibitors and angiotensin II blockers may be helpful as adjunct therapy to reduce proteinuria in steroid-resistant patients. It has been suggested that 3-hydroxy-3-methylglutaryl coenzyme A reducing inhibiting drug should be used to treat the hyperlipidemia seen in persistent nephrotic syndrome, but controlled data regarding risk or benefits are not available. Other measures include pneumococcal vaccine, 23 serotype plus 7-valent conjugate given in routine schedule, given in a remission and off daily prednisone therapy. Vaccine can be administered after corticosteroid therapy has been discontinued for at least 1 month. Non-immune nephrotic syndrome, nephrotic children in relapse, if exposed to varicella, should receive varicella zoster immunoglobulin 1 dose less than 4 days after significant exposure. Influenza vaccine should be given yearly. Now, what are the complications of nephrotic syndrome? The most important complication is infection, including spontaneous bacterial peritonitis, which is the most common and frequent infection. There may be other infections like sepsis, pneumonia, cellulitis, and UTI. Streptococcal pneumonia is the most common organism causing peritonitis. There may be gram-negative bacteria like E. coli. Because fever and physical finding may be minimal with steroid therapy, so high index of suspicion, prompt evaluation by culture of blood and peritoneal fluid, and early initiation of antibiotics are critical. Second complication include increased risk of thromboembolic event. The incidence in children is 2 to 5%, which is much lower risk than that in adults. Thromboembolic events include renal vein thrombosis, pulmonary embolus, sagittal sinus thrombosis, and thrombosis of indwelling arterial and venous catheters. Prophylactic anticoagulant therapy is not recommended unless when there is previous thromboembolic event. Aggressive diuresis should be avoided, and the use of indwelling catheters should be limited. Third complication include hyperlipidemia, particularly in complicated nephrotic syndrome, may be a risk factor for cardiovascular disease like MI, which is rare complication in children. Now, the prognosis of nephrotic syndrome. The majority of children with steroid-responsive nephrotic syndrome have repeated relapses, which are generally decreased as child grows older. The patients who respond to steroid therapy and who have no relapse during the first 6 months of life after diagnosis tend to have an infrequently relapsing course. It is important to tell the family that the child with steroid-responsive nephrotic syndrome will not develop chronic renal failure. The disease is rarely hereditary. The child, in absence of prolonged cyclophosphamide therapy, will remain fertile. To minimize the psychological effect of the condition and its therapy, children with idiopathic nephrotic syndrome should not be considered chronically ill and should participate in all age-appropriate childhood activities and maintain an unrestricted diet when in remission. Children with steroid-resistant nephrotic syndrome, mostly due to focal segmental glomerulosclerosis, generally have a much poorer prognosis. These children develop progressive renal insufficiency, ultimately leading to end-stage renal failure, requiring dialysis or renal transplantation. Recurrent nephrotic syndrome occur in 30 to 50% of transplant recipients with focal segmental glomerulosclerosis. Secondary nephrotic syndrome. It should be suspected in patients with onset of disease more than 8 years, hypertension, hematuria, renal dysfunction, extrarenal symptoms like rash, arthralgia, fever, or hypocomplementemia. Causes include 1. Glomerular disease as membranous nephropathy, membranoproliferative glomerulonephritis, post-infectious glomerulonephritis, lupus nephritis, and Henoch-Schönlein purpura. 2. Infection in certain areas of the wall. Malaria and schistosomiasis are the leading causes of nephrotic syndrome. Other infections include hepatitis B, C, filaria, leprosy, and HIV. 3. Malignancy, especially in adults, as carcinoma of lung and GIT. Lymphoma, especially Hodgkin type. Nephrotic syndrome can develop before or after malignancy is detected. Resolve as tumor regress and return if the tumor recur. 4. Drug and chemical are as penicillamine, captopril, gold, non-steroidal anti-inflammatory drug, mercury, compounds, ethosuximide, etimazole, chlorprobamide, trimethadone, and phenytoin. And the last subject is congenital nephrotic syndrome, which is defined as nephrotic syndrome manifesting at birth or within 3 months of life. A number of structural and functional abnormalities of the glomerular filtration barrier causing congenital nephrotic syndrome have been elucidated. It is classified as primary or secondary to a number of etiologies such as a neutral infection like cytomegalovirus, toxoplasmosis, syphilis, hepatitis B, and HIV. Infantile systemic lupus erythematosus or mercury exposure. Primary congenital nephrotic syndrome is due to a variety of inherited syndrome as Finnish type congenital nephrotic syndrome, Dennis-Drash syndrome, and Persson syndrome. Clinical presentation includes severe generalized edema, poor growth and nutrition with hypoalbuminemia, increased susceptibility to infection, hypothyroidism when there is urinary loss of thyroxine-binding globulin, and increased risk of thrombotic event. Most infants have progressive renal insufficiency. Treatment of secondary congenital nephrotic syndrome is by treatment of the underlying cause, while that of primary congenital nephrotic syndrome include intensive supportive care as IV albumin and diuretics, regular administration of IV gamma globulin, and aggressive nutritional support, which is often parenteral, with attempting to decrease urinary protein loss with angiotensin converting enzyme inhibitors, angiotensin 2 receptors inhibitors, prostaglandin synthesis inhibitor, or even unilateral nephrectomy. If conservative management fail and patients suffer from persistent anasarca or repeated severe infection, bilateral nephrectomies, and chronic dialysis is initiated. Renal transplantation is the definitive treatment of congenital nephrotic syndrome with reported recurrences even after transplantation. شكرا جزيلا لكم لإصغائكم.